Hi, my name is Aman. Today I'm going to talk about two approach to catheter ablation for persistent atrial fibrillation. Definition. Atrial fibrillation is the most common arrhythmia in clinical practice. Catheter ablation is the treatment of choice for symptomatic patients with recurrence despite antiarrhythmic drugs. Most tires for paroxysmal atrial fibrillation come from the pulmonary vein, so ablation involves creating circumferential lesion around the veins to electrically isolate them from the rest of the left atrium.
Welcome back. Well, Dr. Link and I are now joined with cardiovascular surgeon Nikhil Polo. Jake, thank you for joining us in this conversation.
Well, thank you for
I'm
having me.
going to start it off with Dr. Link because earlier in the show we talked about the treatments for AFib, that they come and go, and what options are best. What are the best options with persistent AFib?
So persistent atrial fib is a very difficult condition to treat, and there aren't a whole lot of good options. It's a much more advanced condition, and so we generally try to be more aggressive, both with medications and with surgery. And so one of the things that we're proud to be able to offer is both standard catheter procedures as well as hybrid surgical ablation.
Dr. Jake, that's where you come into play to talk to us about what is hybrid ablation.
So it's a very good question. So typically we, like Dr. Link mentioned, there's a catheter ablation and then there's surgical ablation. But usually surgical ablation requires open heart surgery in the hospital stay. So hybrid ablation is where we take the big things or the most key parts of the surgical ablation, which is ablating the parts in the back of the heart, which is very hard with the catheter, and then let Dr. Link do his part, which is easier for him. And these things have been going on in this country and in Europe for a while and have good results. So that's what we're trying to offer
Right,
here.
and why do that hybrid ablation?
So we get the best of both worlds, where the catheter can't reach, we can reach with the surgery, but we can't reach, the catheter can.
So okay, that makes sense. So then, Dr. Link, who should consider this procedure?
So essentially anybody who has persistent atrial fibrillation where it's giving them problems should certainly be considered for this. And we generally like to be more aggressive and go with the hybrid approaches because of the advanced disease state. And these, as Dr. Jake mentioned, these are areas that are hard to get to or impossible to get to based on the anatomy.
And how long does that last, and is there what's the recovery like for that?
So with the surgical or the hybrid surgical approach, they're usually in the hospital for a day or two, and usually they're out and about in a couple of weeks. They're back to what they want to do. And that's the reason why we like the hybrid approach as opposed to open heart surgery. We're in the hospital more, your recovery after surgery also is much longer.
Wow. Things have come a long way. Thank you, doctors, for sharing this incredible information with us today. Thanks for being here.
You're welcome.
Thank you.
Sure. Well, coming up next, more.
Application in medicine. Catheter ablation for persistent atrial fibrillation is more challenging and is associated with less favorable outcomes. To improve outcomes, ablation strategy, the substrate that mainstrain fibrillation is often added to pulmonary vein isolation. Techniques. The two most common techniques for substrate modification are the creation of linear lesion in the left atrium and focal ablation to eliminate atrial signals that show complex activity.
So here we are in the EP lab getting ready to perform ablation for atrial fibrillation. We have the patient on the table, nurse giving final instructions, going off a checklist, anesthesia, getting ready. We describe to the patient one more time what we're trying to accomplish, emphasizing our priority for safety as well as a very efficacious procedure that is very effective for the patient. So we're going to do as good a job as possible, be as careful as possible, and have a durable clinical results. Lots of electrical connections. The large patches are for the mapping system. The other electrodes are for the various monitoring systems. To keep track of the patient, we start with a transesophageal echo, passing the echo probe through the mouth and throat to the level of the heart. Assess the size and shape of the heart, the valve function, and particularly look for any thrombus that might be lodged in the left atrium or left atrial appendage, and the arrow there pointing towards the left atrial appendage. Doppler signals confirming that there's adequate blood flow velocities in and out of that chamber, confirming no clots. We can proceed, nurse attending to additional technical details. We then obtain venous access, 2 sites of venous access from each of the femoral veins, guided by ultrasound access so we don't puncture any of the arteries in the groin. We perform this procedure under sterile technique, so there with gown and gloves. Each catheter is electrically connected to the console, needs its independent cord, so there's lots of setup getting all of these things organized before we start our procedure. So there we are, laying out all the electrical cables, taking the ablation catheter from its sterile sheath. We'll prep that on the table, make sure the irrigation function, the mechanical function is working fine, no obvious defects in the catheter. Check each of those carefully before we advance them into the patient's body. Here we are checking the deflectable mechanism for the catheter. Later we'll connect it electrically and confirm the irrigation. So here we are positioning it on our procedure table on the patient, attaching the electrical connection to the catheter that will be independently connected to our console. Here is our intracardiac echo catheter that we'll place in the right atrium, obtaining continuous echocardiographic images. There is the 71 centimeter transeptal needle that we'll use to puncture across the inner atrial septum from the right atrium to the left atrium. We need to control that from the groin. Here is a final short sheath being advanced into the venous circulation. That's the sheath that we'll use to position the intracardiac echo catheter. You can see as we remove the dilator, it's actually not that long, maybe 10 centimeters. Here are the very long transeptal sheaths that we'll use to poke across the wall separating the right atrium and left atrium into the left atrium, where we perform the bulk of our procedure. Patient doing very well. We monitor coagulation profile continuously through the procedure as the patient will be on heparin. Here we are checking the irrigation function of the catheter. We have continuous saline infusion through the ablation catheter, both to prevent clot as well as to make the ablation lesions more efficacious, more durable. Check the deflectability of the catheter before we advance them into the body. This is the coronary sinus catheter going through one of our short sheaths. We'll position that in the heart, in the coronary sinus. Here we are getting ready to perform transeptal catheterization, removing that long sheath dilator, flushing sheaths every time. There's our continuous infusion of normal saline through the
Pros and cons. Data from randomized trial comparison methods of ablation for precise atrial fibrillation are limited. Despite the positive data, Gilman suggests that operations should consider more extensive ablation based off linear ablation of complex fractionated electrocardiogram for ablation of precise atrial fibrillation. Whether more extensive ablation improve outcomes is clear. Therefore, this article compared 3 approaches to ablation for precise atrial fibrillation: ablation with pulmonary vein isolation alone, pulmonary vein isolation plus ablation of complex fractionated electrocardiogram, and pulmonary vein isolation plus linear ablation. Issue of play in Ecuador. Patients were recruited from 48 experience centers in 12 countries. Patients were eligible if they were 18 years of age or older and symptomatic persistent atrial fibrillation, refractory to at least one antiarrhythmic agent, and were undergoing ablation for the first time. Exclusion criteria include paroxysmal atrial fibrillation, sustained atrial fibrillation lasts more than 3 years, and the left atrial diameter of 16 millimeters or greater. Conclusion. Among patients with persistent atrial fibrillation, we found no reduction in the rate of recurrent atrial fibrillation where either line ablation or ablation of complex fractionated electrocardiogram was performed in addition to pulmonary vein isolation.
Atrial fibrillation is the most common rhythm disorder in the United States. It affects many people and leads to symptoms of palpitations, shortness of breath, skipped heartbeats, or even a racing heartbeat. Up until recently, the primary treatment for atrial fibrillation was the use of medications, some of which are not tolerated well, some of which have to be continued indefinitely. A new procedure called catheter ablation is a non-surgical treatment to try to fix or improve the atrial fibrillation so that patients may not need to be on medications for the control of the arrhythmia. This procedure can be performed as an outpatient, rarely requiring more than a one-day hospital stay. Patients are able to return back to normal life and activities within 1 week and are able to derive a significant improvement in their symptoms. In conclusion, atrial fibrillation is a treatable condition that now has options that are beyond the medical treatments that were available in the past.